Today's topic for our discussion is arrhythmia. So, this is an ECG lead. Okay, we'll come to this later. So, we know the pathway, conduction pathway, SA node to atria, then atria to AV node. Via the from SA node to AV node, there are internodal pathways. We have three internodal pathway: anterior, middle, and posterior internodal pathway. We know about the names, right? So I'll tell you about their names if you don't know them later. Then from AV node it goes to bundle of His, then the bundle branches, then the Purkinje fibers, and then the last ventricle. So these are the chest leads V1, 2, 3, 4, 5, 6. These are also called precordial leads. The V1 and V2 leads are placed on the right side. Okay, they're called right precordial leads. V3, V4 they are called transition precordial leads because they're in between the right and left. And the V5, V6 they're called the left precordial leads. 1, 2, 3 we know they are the limb leads, right? So first of all, the classification of the arrhythmias. We have bradyarrhythmia, then we have tachyarrhythmia, then we have irregular heart rate. Okay, so very simple: brady, tachy, and irregular. And then lastly, heart block. So this heart block is different from the AV block. So within the bradycardia, bradyarrhythmias, we have sinus bradycardia, sick sinus syndrome, and AV block. In heart block, we have right bundle branch block and the left bundle branch block. Okay, clear? So AV block comes under bradyarrhythmia, and the heart block, there is a separate topic that is out of the four. One of the uh, one is heart block. Suppose brady, tachy, irregular, and heart block. Right and left bundle branch block comes into heart block. Okay. So let's start with the AV block. We'll study AV block, tachyarrhythmia and irregular arrhythmia. Just let me tell you about the tachy and irregular arrhythmias. So tachyarrhythmias, we have three groups: supraventricular tachyarrhythmias, supraventricular, then ventricular, and then ventricular fibrillation. So tachyarrhythmias, we have two in the supraventricular category. First, supraventricular tachycardia, and then ventricular tachycardia and ventricular fibrillation. Supraventricular tachycardia, then ventricular tachycardia and ventricular fibrillation. Clear? So this is tachyarrhythmia. Within the supraventricular tachycardia, all these four are there. Atrial fibrillation first. This is atrial fibrillation. Then atrial flutter. Whenever you get the term AF stands for atrial fibrillation, not flutter. So atrial fibrillation, atrial flutter, AV nodal reentrant tachycardia, and Wolff Parkinson White syndrome. Here, our teachers used to ask how many F are there in Wolff, WOLFF, Wolff Parkinson White syndrome. So atrial fibrillation, atrial flutter, AV nodal reentrant tachycardia, and Wolff Parkinson White syndrome. These four are under supraventricular tachycardia: AF, A flutter, AVNRT, Wolff Parkinson White. In ventricular tachycardia, we have two kinds: monomorphic and polymorphic ventricular tachycardia. Monomorphic means where the QRS complex is of uniform. Every QRS complex is same looking. In polymorphic, the QRS complex are various shaped. Okay. And third category is ventricular fibrillation. Okay. Simple. Now, so we know the bradyarrhythmias. We have sinus bradycardia, sick sinus syndrome, and AV block. Tachyarrhythmias, we have understood the classification. We have supraventricular tachycardia, which has atrial flutter, atrial fibrillation, atrial flutter, AVNRT, and Wolff-Parkinson-White. Then ventricular tachycardia, which has monomorphic and polymorphic ventricular tachycardia and ventricular fibrillation. So tachyarrhythmic classification is clear. Then irregular, we have premature atrial and premature ventricular contraction in the irregular, premature atrial contraction, premature ventricular contractions. This is irregular. And lastly, heart block, we have basically bundle branch block in the heart block, right and left. This is the classification. Classification is done. Sorry. Now let's start with the AV block. Bradyarrhythmias, one of the topic is AV block. So AV block, we have primary, secondary and tertiary AV block. So see what happens in AV block is that the PR interval is getting continuously prolonged. So it is now more than 200 millisecond. Okay, it is now more than 200 millisecond in the first degree heart block, first degree AV block. In second degree AV block, which is called Movitz, which is of two type, 1 and 2. In 1, the PR interval is getting prolonged progressively, and then there is a drop of the QRS complex. See, this is first degree AV block. You see the PR interval, it is prolonged. Okay, it is more than 200 millisecond. Okay, see the Movitz type 1, which is called Wenke-Bach. In Movitz type 1 of Wenke-Bach, see the PR interval, see this PR interval, see this PR interval, and then this is the next P wave, and there is no QRS. See, here you don't have any QRS. Here you don't have any QRS, right? So PR interval is getting prolonged progressively, and then there is a drop. This is Wenke-Bach. In Movitz type 2, PR interval is same. Here is same. Then there is a sudden drop. So in first degree heart block, every P wave is followed by QRS. But in second degree, all of the P waves are not followed by QRS. Now, it can be type 1 or it can be type 2. Type 1, progressively PR interval is getting prolonged, and then there is a sudden drop. In type 2, just all of a sudden there is a signal drop. In third degree heart block, in third degree AV block, you see no atrial impulse reaching the ventricle. Okay, see, P wave is not followed by QRS. Here also P wave is not followed by QRS. Here also P wave is not followed by QRS. Okay, we see separate QRST. We see separate QRST. So here we see P wave, here we see QRST complex, here QRS and T, but the P waves are not followed by QRST. P wave अलग से आ रही है, okay, P wave अलग से आ रही है and QRST अलग से आ रही है. P wave अलग से आ रहा है, QRST अलग से आ रहा है. This is third degree AV block. Clear, right? So AV block is clear, right? Now next is, okay, so atrial flutter, atrial fibrillation, what is the difference? Atrial flutter, it is chaotic and irregular. Atrial fibrillation, it is chaotic and irregular. Atrial flutter, it is regular. It is regular. I'll show you the diagram. Okay, this is atrial fibrillation. See QRS, and see this. How many waves are there? Lots of waves are there. So this is fibrillation. In atrial flutter, we again see the QRS. So that's how we know it is a supraventricular tachycardia, because QRS is there. And see the P waves. See the P waves. Okay. So fibrillation, the top one is fibrillation, the bottom one is flutter. This is atrial fibrillation and this one is atrial flutter. Clear? Atrial fibrillation, atrial flutter. Atrial fibrillation, chaotic and irregular atrial rhythms, and in atrial flutter we have regular atrial rhythms. Now let's study AVNRT. Okay, AVNRT, right? So see, I was telling you that I'll teach you the internodal tracts, right? So anterior, middle and posterior internodal tracts. Anterior is Bachmann, posterior is Thorel. Bachmann, Thorel. मिडिल वाले का नाम क्या है? वी ऑल नो, हम लोग पढ़ भी रहे हैं ना, वुल्फ पार्किंसन वाइट सिंड्रोम. तो जो पार्किंसन है वही है, ठीक है. बैकमैन, वुल्फ पार्किंसन एंड थोरल. Anterior, middle and posterior tracts, internodal tracts. So see what happens in AV nodal reentrant tachycardia. So suppose this is the SA node, यहाँ से AV node में जा रहा है. See, this bigger thing is AV node. Within this AV node, what happened? See, this is the enlarged AV node. Within this AV node, we have two tracts, fast and slow. This is physiological. Physiologically, we have this fast and slow. Clear? So what happens is here, sorry, यहाँ पे आपका फास्ट से भी सिग्नल आ रहा है, स्लो से भी सिग्नल आ रहा है. फास्ट से भी सिग्नल आ रहा है, स्लो से भी सिग्नल आ रहा है. Signal is coming from both fast and slow pathways. But because the signal comes from the fast pathway faster, so what happens as a result? The signal which comes from the slow pathway, it goes back to the fast pathway. Okay, this is AVNRT. So in AVNRT, the electrical impulse is, which is coming down the slow pathway, once it reaches the lower end, it circles back the fast pathway and establishes a re-entrant circuit. This is AVNRT. Okay, this is AVNRT. So what will you find in the X-ray in AVNRT? The X-ray findings that we see in AVNRT is very characteristic. The P wave is hidden. We don't see any P wave. See QRS. QRS. This is T. This is T. QRS T. QRS T. QRS T. There is no P wave. This is AVNRT. Okay. So AVNRT is done. Okay. Now let's study Wolff-Parkinson-White syndrome. AVNRT is done. Now we'll study Wolff-Parkinson-White. So once you understood the AVNRT, Wolff-Parkinson-White will be easy to understand. So here we have an accessory pathway. This is bundle of Kent. This is a shortcut pathway. It will bypass the AV node and will pre-excitate the ventricles. So what will happen, जो AV nodal delay होता है वो नहीं होगा. यहाँ पे जल्दी से जल्दी ventricle को excite कर दिया गया है. And what will happen as a result? We will see a re-entrant tachycardia. Now, just like AVNRT, we have two pathway here now. One is the AV nodal pathway, which is the slow pathway, and this extra pathway, which is the bundle of Kent. This is the fast pathway. So suppose this is the fast pathway and this is the slow pathway. So slow pathway से fast pathway जुड़ेगा and fast pathway में फिर से वापस एक री सर्किट बन जाएगा, re-entrant tachycardia. But WPW syndrome patients are mostly asymptomatic. Incidentally हम ECG में डिटेक्ट करते हैं. क्या देखते हैं? Short PR, delta wave and white QRS complex. कैसे दिखेंगे? Very easy. See this. The PR interval is very short. See this PR interval is very short. Okay, you see this delta wave, you see this delta wave, and the QRS complex is broad, right? This is a broad QRS complex, broad QRS complex. So how do you say it is a delta wave? Because it is slow and slurred. See again, it is slow and slurred. This slow and slurred upstroke of delta wave, almost absent PR interval, मतलब बहुत ही छोटा होता है PR interval less than 120 millisecond, and normal PR interval is between 120 to 200. 20 से ऊपर जाने से हार्ट ब्लॉक कैटेगरी 1 में आ जाएगा, फर्स्ट डिग्री हार्ट ब्लॉक में आ जाएगा. लेस देन 120 PR interval with delta with broad QRS, Wolff Parkinson White syndrome. All right, so we have done our supraventricular tachycardias. Then tachyarrhythmias में we have supraventricular tachycardia, ventricular tachycardia and ventricular fibrillation. ventricular tachycardia देखते हैं. Okay, so first of all ventricular tachycardia देख लेते हैं, फिर fibrillation देखेंगे. fibrillation वैसे दिखा देता हूँ. This is fibrillation. See this is fibrillation. This is fibrillation. Okay, very easy to diagnose. Then tachycardia. This is monomorphic ventricular tachycardia. Very easy. Monomorphic. This is polymorphic ventricular tachycardia. Okay. Now why this is not ventricular fibrillation? This is very so in ventricular fibrillation versus ventricular tachycardia, you have to understand that the heart rate is much faster in ventricular fibrillation. Okay, whereas in comparison your ventricular tachycardia is much slow. It is fast, it is more than 100 beats per minute, but in ventricular fibrillation the heartbeats are more than 150 millisecond, 150 BPM. Okay, and patients will be decompensated. In ventricular tachycardia, patients are mostly like, okay, they're good, but here we don't see any output, no cardiac output in ventricular fibrillation. We don't see any cardiac output, no BP. Okay, right? So this is ventricular fibrillation and this is ventricular tachycardia, two types. Okay, so ये हो गया. Now coming to the sorry, I'm a little bit slow in this thing. Okay, we have understood irregular rhythms, heart block, right and left bundle branch block, and then I'll go to 6 sinus syndrome, the last topic in bradyarrhythmias. 6 sinus syndrome. Before that, let's study the bundle branch block, right and left bundle branch block. In right bundle branch block, you will see RSR pattern. In left bundle branch block, you will get broad R wave. Right is often asymptomatic. Left is also asymptomatic, but will cause symptoms when the patient develops heart failure. So in patients with heart failure, they will require CRT. I'll tell you. Okay. So in left bundle branch block patients, they'll require CRT. Conditions are patients having a heart failure with reduced ejection fraction, or if the QRS is way much more prolonged. See, in both cases of right and left bundle branch block, the QRS is more than 120 millisecond. But when it goes above 150 millisecond, then you should insert a CRT, cardiac resynchronization therapy. Right bundle branch block doesn't require any treatment actually. Only left requires. In left, what do you see? Broad R wave. See this. In the lead V1, we see a broad RS pattern, broad RS, and in the leads V4, V3 to V6, we see a broad R pattern. Why? I am saying in V1 and V2 you will find broad RS, and from V3 to V6 you will find broad R wave. For that you have to understand ECG leads. See, in the leads V1 and V2, okay, in leads V1 and V2, the right precordial leads here, your patient is actually, हम लोग देखते हैं ना कैसे राइट लेफ्ट, राइट लेग लेफ्ट लेग, राइट लेग में राइट अपर लिम्ब में लीड लगाते हैं, लेफ्ट अपर लिम्ब and left lower limb, right? This is the circuit. So here the leads which are placed on the right side, okay, they are opposite to the direction of the lead, so you will not see any R wave, okay, almost absent R wave. But in the V3 V4, यहाँ पे V4 नहीं है, V4 V5 and V6 you will see positive R wave. यहाँ पे R wave मिसिंग है, यहाँ पे बहुत ही बड़ा S wave है, यहाँ पे R wave थोड़ा सा वापस आना शुरू हुआ है, लेकिन अभी भी S wave ही ज़्यादा बड़ा होगा. फाइनली V3 में हम देखेंगे कि R wave इज बिगर देन द S wave. V4 में भी हम सेम चीज़ देखेंगे, R wave इज बिगर देन S wave. एंड इन V5 R wave will be very predominant and S wave will almost absent. ओके, फिर से सुन लो मैंने जो बताया. ओके, सो हम जो देखते हैं लीड V1 एंड V2 में वो होता है RS. ये रहा RS, दिस इज RS, दिस इज RS. So in lead V1 and V2 we'll see broad RS, and lead V3, V4, V5 and V6 you will find broad R wave. This is what we will find in left bundle branch block. Clear? Okay, now right bundle branch block. Okay, right bundle branch block में क्या हो रहा है? You will see RS R dash pattern. Okay, sorry. You will see RS R dash pattern. Okay, RS R dash pattern. Here it is. See, this is normal PQRST, and here is the RS R dash pattern. This is lead V1. So in lead V1 you should not have any R dash. Okay, why? Because in lead V1 and V2 what you see is only S wave, only S wave. In V1 and V2 you should see only S wave, because R wave is absent in V1 and V2. But here after S wave you find another R wave, another F wave which is going upstroke. So this is RS R dash pattern, which is seen in leads V1 and V2 of right bundle branch block. So in right bundle branch block you will see RS R dash pattern and broad R wave and broad RS in the left bundle branch block. Right, so we have covered the bundle branch block also. Now last topic is 6-sinus syndrome. So I was telling you about chest leads V1 V2. See in the chest leads also the P waves will be also missing in the V1 and V2. QRS is missing, R wave is missing in the leads V1 and V2. Also the P wave will be also missing in the leads V1 and V2. And sometimes it may be biphasic, मतलब थोड़ा सा पॉजिटिव थोड़ा सा नेगेटिव आ सकता है, मतलब कहीं पे थोड़ा सा पॉजिटिव है कहीं पे थोड़ा सा नेगेटिव है, biphasic, but it will be positive in V3 to V6. Similarly QRS will be negative in V1 V2, positive in V3 to V6, and in the V1 and V2 you will find the RS, small r capital S, यानी कि छोटा सा R and then deep S. Now 6-sinus syndrome. 6-sinus में 5 चीज़ें आती हैं. साइनस ब्रैडिकार्डी उसमें हो सकता है, ब्रैडिकार्डी होते होते साइनस पॉज हो सकता है, साइनस अरेस्ट हो सकता है. देन साइनो एट्रियल एग्जिट ब्लॉक, इट इज़ नॉट एवी ब्लॉक, इट इज साइनो एट्रियल एग्जिट ब्लॉक, ऐसे नोट से नहीं निकल पा रहा है. साइनो एट्रियल एग्जिट ब्लॉक एंड टैकीब्रैडी, यानी कि थोड़ा सा टैकी थोड़ा सा ब्रैडी, बोथ एट द सेम टाइम. So these are the 5 types of 6-sinus syndrome: sinus bradycardia, sinus pause, sinus arrest, sinoatrial exit block, and tachybrady syndrome. And that is the end of our discussion on arrhythmias.